start, guys. So thanks for joining us. I am sure that there will be more people who join as time goes on, but I am going to start. I think several people are in clinic right now, so they'll probably hop on. I'm going to take a minute to talk about ASCO updates from 2023, and really talking about adjuvant endocrine therapy and beyond. In particular, I'm going to talk about NATALEE, the monarchy update, and the EBC-TCG ovarian suppression study. So let me make this smaller. Please interrupt at any point in time if you have questions, happy to answer them. So this is the NATALEE trial that Dennis Slayman presented for, and what it is, and this is, I'm the site PI here. It is an adjuvant study of ribociclib looking at the 400 milligram dose. It enrolled 5,100 patients in a 1-to-1 randomization of ribociclib with either letrozole or anastrozole, or letrozole or anastrozole alone. And the primary endpoint was IDFS. This is the eligible patient schema, and it's just, I think the thing that's notable is just that it included all node positive patients, irregardless of what their clinic tumor looked like, and then node negative patients if they were either T3 or T4, and then T2 if they had a grade 3 or a Ki-67 greater than 20% or a high genomic risk. So this expands sort of what the eligibility criteria for the monarchy of the abemaciclib trial was. And just looking at who actually enrolled, I think the notable thing, I don't think that there were a lot of men, so it's notable that just premenopausal women made up more than 40% of the population, although T2N 0 cases were allowed. It looks like it was a sort of smaller population, with 20% being 2A cancers. And I think of note, 88% of these patients received chemotherapy, which is most, but not all. And then where we are essentially, so the median follow-up right now is 34 months. And this is just important because we actually use the ribociclib for 3 full years. So this doesn't actually go as far out as 3 full years. So most of the patients, only 20% of the patients have actually completed this 3 years of ribociclib, and we have data after they have discontinued. The only other point here is that discontinuation rates were pretty low and similar across the population. And so this is the outcome slide, and what it shows is that ribociclib does improve IDFS by approximately 3%, with a hazard ratio of 0.75, rounding. And I think all of us are sort of curious as to whether or not the high-risk patients got more benefit. And in this sort of forest plot, we don't see that stage 3 cancers got more benefit than stage 2 cancers, or people who got neoadjuvant versus adjuvant, or even node positive versus node negative, although you see that the confidence interval here on N0s is wider. And then this is distance disease-free survival, so a secondary outpoint or outcome that they're looking at, and you see that the hazard ratio is 0.73 for this and was statistically significant. Again, recognizing that the median follow-up is really only 34 months, and so most of these patients are still actively on ribociclib. And there was a trend towards improved overall survival, but this is not mature. And this is just to say that the side effects are sort of what we expect them to be, that we see a lot of neutropenia, some LFT abnormalities, and a little bit of QT prolongation, although it's not particularly notable, or it's in the single digits is what I'll say. And then same for pneumonitis. It looks like there are a couple more cases in the ribo arm than in the AI alone arm. And so what my take homes on Natalie are is that the eligibility is more open than monarchy, that it included some N0 cancers, that the benefit seems pretty uniform across the groups. And I actually have this wrong. So it was IDFS was actually 0.76 and the DDFS was 0.74 or 0.73, but really to recognize that ribo is given for 3 years, so this doesn't capture events at the completion of ribo, that overall survival data isn't mature yet, and that this is an expensive drug, both for the cost of the pill, but then also in terms of clinic and patient time. I think that this does show an advantage in that it gives 400 milligram dosing, which is better tolerated, and we're still awaiting the manuscript, and this may be an option for patients in the coming years. I'll pause very briefly for questions on this. Anybody have anything that they want to ask about right now? Okay, I'm going to move on. So the next trial is going to be the update of monarchy, which was presented by Erica Hamilton. And monarchy, the study design was looking at 5,600 patients that were randomized 1-to-1 for abemaciclib with endocrine therapy versus endocrine therapy alone. It was given for 2 years. And it's been presented a number of times and was a positive trial, and you know that we are all using it. This was a third planned analysis, and what they used this to look at was safety and pro-analysis of older versus younger patients. They looked at a split at 65 because the percentage of patients that made up or who are over 75 was really small. Here are the curves of all comers, just to remind you that it is a drug that we give for 24 months. We saw that there was already benefit at this 24 months, but at subsequent time point analyses, we have seen these curves continue to diverge and show improvement for both IDFS and DRFS. And so then they looked at those less than 65 versus greater than 65. And you see that in those who are over 65, there may be a little bit bigger tumors and a few more patients with N2 or N3 disease, but it was pretty similar. And when you look at what the outcomes are by age, if you're looking at IDFS, we see that they are relatively similar. Of note, they're a little bit lower in those who are over 65 regardless. So you see that there's about a 4-point spread, 3 to 4 point spread between both of these. And then in distant recurrence-free survival, again, you see slightly lower numbers in this older patient population, but it exists both in the endocrine therapy arm as well as the abemaciclib arm. And what we see is that, again, the side effects in this population were fairly similar, and they said that they were similar. I just think numerically we think about this, and when you're thinking about patients that have grade 3 diarrhea, and there are five more, that may be influencing things a little bit, and same for fatigue. So maybe a hint of slight increased side effects in this older population. This is maybe the most notable part of, or one of the most notable parts of their analysis, which shows that dose adjustments were more common in older patients, maybe reflecting side effects or tolerance of those side effects. And I think that one of the points that was stressed, and I think is important to see, is that 19 patients, or percentage of patients, and this is a little confusing, but there was a much higher proportion of patients who are over 65 that were discontinued without prior dose reduction. So it seemed like in this patient population, if something bad happened, that they maybe it was either really bad and they just stopped it, or it was bad enough that they just weren't interested in retrying. And this is a great slide that I think can be reassuring for all of our patients. So this is including all ages, and this is looking at RDI. So this is relative dose intensity, and it looks at relative dose intensity of the drug, meaning how many breaks you had and the dosage that you got, and looking at 3 different levels. And you see that there's not particularly notable differences in these in the different groups, suggesting that if you dose reduce, that you have similar efficacy across the groups. Oh, and then my take homes for Monarchy and those over 65 is that it took a little bit more risk or disease for patients to go onto the trial, and they had higher comorbidities, ECOG performance statuses, and received chemotherapy less frequently. They all still had benefit, although numerically slightly lower rates for both endocrine therapy and endocrine therapy with abemaciclib together. And there was numerically higher diarrhea and fatigue, but not statistically significant. And they had higher rates of dose reductions and interruptions. But the efficacy at all 3 RDI was similar, and that's across all ages. So I think that that's reassuring for us when we're dose reducing our patients. And I think it's worth it to offer and try in older patients, and we may need to dose adjust, and dose adjustments probably don't greatly affect outcomes. So that's something that we can think about. And this was asked, this is my personal feeling. I think that we can think about potentially an escalation rather than de-escalation strategy with these patients, but I'm curious as to what others think. In the setting of timing, I'm going to keep going and I'll ask for questions at the end. So the last study or abstract that I'm going to present to you guys was the EBCT-CG study looking at patient-level meta-analysis of almost 15,000 women premenopausal in 25 randomized trials. And you see that Dr. Davidson is one of the authors on here. So maybe we can pick her brain if she has ideas about this. Really cool and important study that, you know, these meta-analyses always are. So it was looking at individual patient data from ovarian ablation, either surgery or irradiation, or ovarian suppression versus not. And it looked at premenopausal women with ER-positive disease, unknown ER status, and early stage breast cancer. And the primary outcomes were looking at recurrence and mortality. And they looked at 27 trials, ended up being that there were 23 trials who had premenopausal women at randomization, about 15,000 patients. They split it up into the use of chemotherapy. So there were 12 trials, including 4,000 women who had no chemotherapy. There was the second set that chemotherapy was given prior to randomization, and premenopausal status was confirmed afterward, and that included 2 trials. And then there was post-randomization chemotherapy, which could result in women experiencing chemotherapy-induced menopause. That was 14 trials and 7,700 patients. And I'm giving a lot of information in this because I just find it to be really interesting. And given that it's a meta-analysis, there are a lot of different ways to kind of slice and dice it. So this is looking at recurrence, and this is looking at no chemotherapy or remain premenopausal after chemotherapy. So these are women who have menses, and we see that they have increased benefit of almost 10% at 15 years from ovarian ablation or suppression. If they were premenopausal before chemotherapy but uncertain after, the benefit was smaller, although still significant, with about 1% absolute benefit. Here's a forest plot, and these are the trials. And I just like to point out that a lot of these, so this is ovarian irradiation, oophorectomy, TAM plus goserelin for 2 years, goserelin for 2 years, ovarian ablation, TAM plus ovarian ablation, TAM with goserelin, or like with any of the options, goserelin, goserelin, and many of these where it's ovarian suppression with goserelin, it's only 1 to 2 years. So that's, I think, important to recognize when you're thinking about what the trials are and what they actually did. But you see that in these women who didn't receive chemotherapy or were premenopausal after chemotherapy, there is a clear benefit to ovarian suppression. We see that this is much smaller in those who got chemotherapy, and we weren't able to prove whether they had menopause after, or if they were still having menses afterward. I think this is a really important slide, because this is looking at recurrence in premenopausal women who got chemotherapy, but we were uncertain after. And this is as you would kind of think about it. For our youngest patients, it appears as though there is probably benefit, although this covers, this goes over 1. And similarly, down we see that we don't have any benefit for those women who are over 50, or those who are in those who are 45 to 49, we see less benefit. We see here, if you are still menopause, or if you still are having menses, it doesn't matter how old you are, that you still get benefit after or with ovarian suppression. And then again, this is looking at those who are less than 45 versus 45 to 54. We see that there's benefit regardless, although younger patients seem to get more benefit. This is mortality, and this is a critical slide because we are always thinking about mortality benefit, and we see that breast cancer mortality and all-cause mortality are all improved. Then we look at tamoxifen. Most of the studies that looked at tamoxifen used suppression, versus the ones that did not include tamoxifen used ablation. And so this data is a little bit conflated, and it's important to recognize that. So without tamoxifen, but with ablation, you see a very striking improvement with ovarian ablation or suppression, versus with tamoxifen, the improvement is less. But it's hard to know what the benefit would be if you had full ablation or more persistent suppression here in this tamoxifen group. And this is kind of looking at the converse, looking at ablation versus suppression, recognizing that 20% received tamoxifen versus 86 received tamoxifen here. And so my take homes are that ovarian ablation and suppression decreases recurrence and mortality, that the larger benefit is seen in patients who don't go through chemotherapy-induced menopause, or likely didn't, so that they got chemo and it was unknown but young, and that there's a larger benefit seen in those who didn't take tamoxifen. And one of the limitations to this study is that it didn't look at the use of aromatase inhibitors at all. So that is it. I will stop sharing and welcome any questions.
Can you help us with the 2 years versus 5 year ovarian suppression piece?
I would love, I mean, this data I don't think speaks to that. I think that, you know, when you have ablation or irradiation, you're getting full permanent, hormone suppression for all
potentially 15 years.
Yeah, but I don't think that we have 5-year data. They didn't include the arms looking at 5-year data, say from soft and text. And Nancy, you're an author on this. I don't know if you want to speak to it. They really wanted it to be a clean analysis, is my understanding.
The data don't exist, Hannah. You know, there haven't been any trials to speak of that have really looked at that head to head. I think the trial that people are interested in is the Japanese trial that only used 2 years of ovarian suppression and suggested a good benefit. But I don't know what to do with it. I can tell you, because I was at the table when we designed a bunch of these trials, that we picked 5 years arbitrarily because that's how long we gave tamoxifen. So it wasn't based on any science particularly.
Right. I think it's just very difficult because that Japanese study does suggest that 2 years is enough, but obviously it's pretty different if you're talking about a 45-year-old than a 35-year-old. You know, it's just complicated, but it's miserable for the 35-year-old. So it's really tempting to say to them, look, just put up with this for 2 years and then we can cross you over to a kinder, gentler endocrine therapy. But I wish we had more data. The data, of course, that we are all really wanting is the randomization versus to pure endocrine aggressive treatment versus chemotherapy. And that also is a trial about to happen.
Yeah, the new one coming. Again, we had an ill-fated trial, the Per K trial back in the day where we tried to do that. and its accrual was exactly 0. So it just wasn't a concept that was embraced 10, 15 years ago.
If there aren't any other comments, we can move to the next presenter. Hannah, are you? Oh, Jen, I see you on. Whoever's next.
Hannah, if you're up, are you available?
I'm in the middle of a clinic room. I'm waiting for my own private office in a minute.
Okay. Lynn, are you ready?
Let me just screen share quick. Everybody see it okay? Okay, great. So I'm going to be talking about tumor infiltrating lymphocytes. This was a big focus of ASCO this year, with a lot of presentations and a lot of abstracts, including a lot that were spotlighted. So some exciting emerging data coming out. So the first presentation that I was going to talk about was this work presented by Megan Tesh et al. That was looking at the association of tumor infiltrating lymphocytes with clinical pathologic characteristics and prognosis in young women with hormone receptor positive breast cancer. And as I'm sure most people in this group know, so far, most of the data regarding TILs is most promising in the triple negative or HER2 positive space, particularly the triple negative space. So looking at TILs in the hormone receptor positive space is certainly an ongoing need. So in this study, they utilized a prospective cohort of women who were diagnosed with breast cancer, specifically before age 40, and they analyzed patients who had stage 1 to 3 disease that were hormone receptor positive and HER2 negative. Their final cohort was about 390 patients. And they assessed the extent and composition of immune infiltration and then correlated that with the clinical pathologic features and survival incomes. And they specifically assessed TILs using multiplex immunofluorescence and looked for different TIL subtypes, including cytotoxic T cells, T helper cells, Tregs, exhausted T cells, and PD-L1 positive cells. And so they had a few interesting findings. First, older patients had higher expression of certain TIL subtypes in both the stroma and tumor. Specifically here, you can see that older patients had higher proportions of cytotoxic T cells, exhausted T cells, and T helper cells. I think worth noting is that a reminder that this cohort was 40 and younger. So though they're saying this is, quote, older patients, older in this case is 36 to 40, which is still quite young in the general context of breast cancer. Another interesting finding was that Black patients had higher stromal expression of cytotoxic and T regulatory cells. And you can see that this is a pretty dramatic difference here with patients having 88 to 82% compared to numbers closer in the 40 to 50% for other populations. Another finding was that aggressive subtypes tended to have higher T helper cell expression, and then high-grade tumors had higher immune marker expression. So and then they subsequently also did a multivariate analysis looking at analysis by like a continuous 10% increase in TILs. And they found that basically all subtypes have some survival benefit. Specifically, the cytotoxic T cell expression was associated with improved overall survival when present in the tumor, but not the stroma. High T helper cell expression was associated with improved breast cancer-free survival and disease-free survival. High T regulatory cell expression was associated with improved breast cancer-free survival and disease-free survival. And then high PD-L1 expression was also associated with improved breast cancer-free survival, disease-free survival, and overall survival. So altogether, key conclusions were that the distribution of TIL subtypes in young women with hormone receptor positive breast cancer had variations according to race, age, and grade. Again, I think age is taken somewhat with a grain of salt, as it was still a relatively narrow age distribution. Most of the subtypes were associated with improved outcomes in some form in these younger patients. And then in terms of areas of future research, characterizing immune cell subsets could help better refine the prognostic value of TILs, which again has not been clearly defined yet in hormone receptor positive breast cancer. And I, similarly to Rachel, will probably wait till the end to do discussion and questions if that's okay with people, because there are quite a few presentations for this. So one of the other interesting presentations that was spotlighted in the neoadjuvant abstract session was a presentation by Robert Hills et al. That was looking at do tumor infiltrating lymphocytes predict benefits from trastuzumab therapy for HER2 positive breast cancer. And this was a meta-analysis of patients from looking at 400 and 168 women across 5 randomized trials. So again, this is a meta-analysis of randomized trials that utilize trastuzumab in early breast cancer. The goal was to assess the prognostic value of TILs in these trials that looked at chemo plus adjuvant trastuzumab and assess if TILs impact the magnitude of benefit. TILs were quantified using the TIL working group methodology, again, looking at just over 4,000 women, and there were 5 randomized controls that they ultimately drew from. And so what they found was that higher TILs were associated with lower risk of recurrence. There was no significant correlation with age in this study. And then TILs were lower in women with ER positive, node negative, better grade tumor, which is similar to other findings that have been reported, including the last presentation that I highlighted, where similarly tumors with higher grade tended to have higher TILs. So key conclusions that were takeaways from this study was that analysis confirms a prognostic effect of TILs in the HER2 positive population. They did look to see if there was a natural sort of cutoff to use as a definition for high or low, and they didn't find any natural cutoff. And there was no indication that the proportional reduction in recurrence with trastuzumab varied by TILs. For every 10% increase in TILs, the rate of recurrence lessened by 14%. They didn't define any groups with very low risk of recurrence, but there were small numbers of patients with high levels or node negative tumors. And then there was no evidence of interaction between TILs and the effect of trastuzumab. So they noted that there was substantial absolute benefit from trastuzumab, but that was irrespective of TIL status. So moving on, another key talk was looking at characterizing the immune microenvironment in matched primary and metastatic breast cancer lesions based on the Aurora study. This was a presentation by Hilbers et al. That was spotlighted in a larger session talking about the immune environment and breast cancer. In this study, they analyzed patients with metastatic breast cancer who received no more than 1 line of therapy in the metastatic setting. This was done through the Aurora program, and the goal of the study was to characterize the evolution of the immune landscape in paired primary and metastatic lesions. They did this using RNA sequencing on paired primary and metastatic lesions, and then TILs were scored using the TIL working group methodology, as we've seen previously. So overall, one of their key findings was that tumor infiltrating lymphocytes decrease with disease progression. So metastatic sites had less TILs compared to primary sites. And then another interesting finding was that metastatic biopsy with high TILs are associated with better overall survival, specifically in triple negative breast cancer. Again, sort of keeping with findings that TILs are prognostic, particularly in triple negative, but this was nicely defining that more so in the metastatic space. They did show that there was no statistically significant difference in immune cell composition between primary and metastasis in de novo metastatic disease, which was interesting. So key conclusions from this study were that TILs were decreased in metastatic lesions compared to primary lesions. The only exception was in lung metastases. In triple negative breast cancer specifically, high TILs, which in this study were defined as greater than 20%, were associated with longer overall survival. Metastatic lesions were characterized by relatively higher proportion of macrophages, Th1 cells, but had fewer B cells, Tregs, and CD8 positive T cells compared to primary tumors. They also noted that lesions with high TILs, again defined as greater than 20%, had more Tregs, B cells, and CD8 positive T cells, and fewer Th1 masked and NKT cells compared with those lesions that had lower TILs. And then, as mentioned on the previous slide, primary and metastatic lesions in the de novo setting showed a actually similar immune landscape and had more BCR clones in common than recurrent disease. So, no sort of practice changing conclusions from this yet, but one sort of key takeaway that was made during the session was that in cases with multiple metastatic sites, the choice of biopsy site might affect the likelihood of observing an immune response. So in the metastatic setting, some sites appear to be more enriched than others, and so that might impact which site you want to biopsy if you're trying to meet eligibility criteria for treatments and trials. And then the last presentation that I was going to go over was looking at a presentation by Daniel Stover et al. That was looking at the association of tumor infiltrating lymphocyte quantity with survival in patients with metastatic breast cancer receiving microtubule agents. And this was based on an analysis of the CALGB 40502 study. So again, it used study from the CALGB 40502 data, which was a phase 3 trial of metastatic breast cancer patients receiving first-line chemotherapy plus or minus bevacizumab. All told, there were 443 patients who were evaluable for TILs. Their aim was to evaluate quantity and survival outcomes in the metastatic setting, specifically without checkpoint inhibitors. And again, TILs were evaluated using the TIL working group methodology. And here they defined low as less than 5% and high was defined as less than or equal to 5%. As you can see, this is variable from the past presentation that we just saw where that was defined as 20%. So here they showed that TILs are significantly associated. Sorry, I'm going to pause for a second while the overhead announcement goes.
Maria Hernandez to the first floor info desk.
So TILs were significantly associated with progression-free survival and overall survival in metastatic breast cancer patients receiving first-line chemotherapy, and that was independent of the treatment arm. Additionally, when they controlled for hormone receptor status, TILs demonstrated lower hormone receptor or lower HR and a non-significant trend towards association with progression-free survival and overall survival. And then they also looked at paired samples, and there were 100 patients who were evaluable, and they found, similar to the last study, that TILs were lower in metastatic disease compared to the primary. And then again, this also demonstrated that TILs varied by metastatic site. So sites with very low TILs included the bone, skin, and liver in comparison to, say, the lymph nodes where TILs were relatively higher. So key conclusions were that TILs were associated with progression-free survival and overall survival in metastatic breast cancer patients receiving first-line chemotherapy, which was independent of treatment arm. And there was a trend toward independent value adjusted for other prognostic features. And then they also looked at immune activation measured by TILs, which was significantly lower in metastatic tumors compared to primary breast cancer. And then again, they also found that this was variable by metastatic site. So key takeaways overall were that TILs really continue to show promise as both a prognostic and predictive biomarker. This continues to be most heavily true in triple negative breast cancer and with HER2 positive subtypes. But unfortunately, exact utility is still undefined in clinical practice and is an ongoing area of research. TILs, another key sort of takeaway and talking point is that TILs are frequently defined as a binary variable, as we saw. So with a cutoff that distinguishes them as being high or low, but there's an ongoing need to define what that cutoff is, and it's really variable depending on what study that you look at. So there is a need to better define what those cutoffs are and in which setting we use them. And then I didn't highlight this here, but there was also in the larger community, there were a lot of talks at ASCO this year, also looking at interest in automating TIL scoring with digital pathology or AI and machine learning tools. So lots of interest in seeing if that process can be automated to offload some of the workload from the pathologists. And on that note, Jen and I just wanted to spotlight that we currently at our institution do not routinely report TIL status, but we have some funding from my MOSH fellowship where we're working with Mark Kilgore to look at TILs specifically in the triple negative population and get reporting back on 50 patients. And so what we're trying to define is the workload that this puts on pathology and the value defined by medical oncology. So the pathologists are going to be completing some surveys about how this impacts their workload, and then we'll be sending surveys to all of you about perceived benefit of that information, hopefully to make a strong case that we can get this reported here as well for us, both to help guide potential treatment decisions and to hopefully be able to use for our own studies and things moving forward. So. All right, I'm going to go to the chat and see if anything popped up in the chat while I was talking.
Thanks, Lynn. Maybe a quick question or observation. The study of the young women in the ER positive disease I thought was pretty interesting because it looked like the levels of TILs were much, much higher than what we see in older patients. And again, cross-trial comparisons. All of these things seem to point towards younger women having more aggressive disease in every way that you look at it. It's just curious if they commented on that those incidents seem much, much higher than I would have expected.
Yeah, I'll pull back, Jen, and see if I can find a specific comment on it. But that was my takeaway too, is that young women TILs tend to be represented more highly in aggressive disease, and young women tend to have higher proportion of TILs. So I think all sort of goes to continuing to need to define where TILs are most useful, but it's certainly in these higher risk populations can be helpful and hopeful predictors potentially of response to therapy and things. But I'll try and pull back because that was a key takeaway for me too.
And of course, wondering what the ER positive subset will have as well in terms of TIL or some other immune phenotype. So nice job, Lynn. That was very interesting. Can you all see the slides and hear me okay? Okay. So I had the privilege of being a poster discussant at ASCO, and so this is the talk I gave there. You know, this is really about our work with molecular imaging. And this is a talk about some other biomarkers than the ones you're used to me talking about, as well as the one you're used to me talking about. Okay, so the first poster I got to review was actually about immunohistochemistry. These are my disclosures. So, you know, I think what's interesting about molecular imaging is you can actually look at a macroscopic picture. You know, we've all been focused on these molecular signatures, but and obviously there's a huge relevance to that, and you know, PI3 kinase is an important pathway, but there's also an opportunity to look at clusters of cells. You know, Kevin's work looking at how cells work as a group. The tumor microenvironment, what Lynn just talked about, also very important. And also just the routine use of imaging to understand tumor extent and to understand whether or not you are molecularly active in a certain way, like taking up glucose or taking up estrogen or PSMA. So lots of different levels to look at cells and lots of different tools out there. Obviously, PSMA has been rather important for prostate cancer. So I think one of the advantages of molecular imaging is that you don't have to do an invasive procedure. You get density of the molecular target without bothering the patient and without, going somewhere deep that could be dangerous. However, getting a slice of tissue is also obviously very important because then you can really look at it in detail and look at background stain versus the presence of a marker, and you can look at things like the TIL. So I think there are a lot of clinical tools and needs and a lot of knowledge gaps. In breast cancer, I think we're really struggling still with which kind of patients benefit from CDK4/6 inhibitor therapy. Should you keep going with it or should you jump over to chemotherapy? And at the next presentation, Jen will talk about a really important trial that was presented at the meeting, about maybe that just endocrine therapy alone for some people could be really useful before you get out the expensive toxic agents. FES PET has been approved by the FDA. It's now within the NCCN guidelines and used for aiding in diagnosis and really prognosis and verifies the extent of ER-positive disease. It can be helpful to resolve a diagnostic dilemma and also predict clinical benefit, meaning lack of progressive disease, including stable disease and response for endocrine-based therapy, which includes using CDK4/6 inhibitors at the time of treatment selection. We recently worked together to put together appropriate use criteria with a SNMMI ASCO group and publish that and hope that we can ensure that these tools get used in an appropriate fashion so that more patients can benefit. I think, honestly, the big use of FES PET that I think people don't realize is something that Porny worked on when she was here, which is that many patients don't get a diagnosis. They don't get a metastatic diagnosis with tissue for a bunch of logistic reasons. And in the state of Washington, that is probably as high as 50%. So prostate cancer has multiple PSMA-like tracers. But what's interesting is PSMA is actually an endothelial tracer. It's not actually prostate specific, and it reveals neoangiogenesis. So many solid tumors, including breast, and in particular, triple negative breast cancer, have a PSMA uptake. So we looked at 3 different abstracts. This is an abstract that is really a sub-study looking at IHC testing in patients who, a subset of patients who participated in the PEARL study. There were a couple PEARL studies, one with pre and one with postmenopausal women. They're looking at the difference between giving capecitabine versus a CDK4/6 inhibitor. And they showed that when you give the CDK4/6 inhibitor, you actually have a pretty similar, if not better, response or duration of response. So they actually dove in and looked at cyclin E expression, and they looked at where the cyclin E was located, whether it was nuclear or cytoplasmic, and C shown here. And they grouped the patients into these 4 subsets with regard to whether or not they had that staining in the nucleus and in cytoplasm. And they looked at, a forest plot and, multiple aspects. And all of these really don't show anything except that one in the lower corner on the left, which shows that actually they seem to have picked out which subset benefits from capecitabine more than the CDK4/6 inhibitor based on this ratio. It's really a small subset, but it's an interesting marker because recall that we don't really understand how to select patients for CDK4/6 inhibitors at any point in their journey. So they concluded that palbociclib and capecitabine are equally effective for tumors which are cyclin E nuclear positive and negative tumors, and when you look at this by progression-free survival. But in tumors that were positive for the low molecular weight cyclin E isoform, palbociclib was significantly inferior And these are patients that probably really do need some sort of chemotherapy. And there was no difference for the other negative tumors. And when you push out just to the cytoplasmic cyclin E, it's even more pronounced, the difference. This is not ready for prime time, but it's really interesting and really important, because I think it would be nice for patients if we could get better at how to select therapy. So this next study that I was asked to talk about is a large study from France mostly, but other groups in Europe participated. Mostly from Italy. Other groups in Europe participated to compare looking at FES actually to select treatment, which is something I think we'd all love to do. So they looked at first-line therapy, which in retrospect, perhaps we should have done second line, but this is what we're doing. So first-line therapy, all patients underwent FES PET or FES PET if you're from France. And the patients who had significant uptake, 2 is the usual cutoff, 1.8 might be another possible way to cut it off. But those patients simply went on to endocrine therapy, which was what most people were going to get, physician's choice. But then they randomized the group with a low FES. I asked them quite specifically whether they drilled down to look at this at a lesional level, and they really couldn't answer that question yet. They're going to need to answer that question in order to publish this paper. But what they did is they randomized the groups with a low FES on average to either chemotherapy or endocrine therapy. And when they say endocrine therapy, they mean single agent endocrine therapy or endocrine therapy plus a biologic. But notice that that's really only one patient that got exemestane, because the standard of care is different. So really it was chemo versus single agent endocrine. And you can see that it's a usual mix of patients. It's just not enough patients. But what they saw is that the survival was best in the ER positive patients, not surprisingly. That's really the prognostic issue. And then with the randomized patients, there is, a not statistical difference, but it does suggest that the patients with the low SUV got something out of this. Hang on. Yeah, I think that's all I was able to take from the data. So basically, FES predicts that you're going to benefit from endocrine therapy, and the patients with a high FES did well. Not surprisingly, that's the majority of patients. The majority of patients do really well on endocrine therapy first line. And they have a better survival than other patients who are not endocrine sensitive. But they did notice that in endocrine sensitive patients, progression-free and overall survival with AI was better than the other blocking agents. This is not a planned analysis, and it's not statistically significant. But they did show that you could use FES as an integral biomarker. This is something we would love to do, randomizing to chemo or endocrine therapy. And the low FES tumors appeared to benefit from the initial chemo. But of course, they were the prognostically poor patients, and they had an inferior survival overall. And the group really is just too small to draw significant conclusions from. So this brings up just the challenge of working in this space, but it's nice to see consistent data across institutions. And then finally, the PSMA abstract. So this is the PRISMA trial and is being done in Brussels primarily, but we may have an opportunity to either participate in this trial or participate in a similar trial. So a question I get a lot is whether or not you could use FES PET, the tracer, whether you could turn it into a theranostic. And the answer is no, that's not safe, because FES is cleared by the liver. So there's no chance that we're going to be doing that kind of a study. However, PSMA can be turned into a theranostic. And so the goal in this study is to look at PSMA as a biomarker, but ultimately to test it as a theranostic. They did not present anything using it as a theranostic, and I think there is rare incidents of it being used in breast cancer in Germany, maybe in one small publication. So that's not ready for prime time. But what's interesting is looking at PSMA as a biomarker right now and thinking forward about whether or not we could use it as a theranostic. So they picked triple negative breast cancer because it has a higher uptake of PSMA than the other breast cancer subtypes, which is interesting because, you know, this is a subtype without a biomarker really. So heterogeneity was noted, and it's a really mixed bag of patients in their first 10. Half of the patients had a triple negative biopsy of metastases, but they had previously had I think 4 of them had ER positive tumors, and 1 of them had a HER2 positive primary. But the SUV was higher in younger patients, in de novo metastatic triple negative, and in the patients perhaps with a TIL, but certainly the ones that were PD-L1 positive. And 2 patterns emerged, one that had significantly higher uptake than liver background, and they plan to analyze more patients. So this is just a peek at what they're going to do. And the questions I asked them before presenting this was, well, what about PSMA levels in the tissue, PSA, androgen, all that? They're planning to do it, but they didn't have data about that to share at the time of this presentation. And so here's just a picture, and you can see that this is a pretty bright uptake when you look at the comparison between FDG and the PSMA PET. You can also see the nonspecific salivary gland uptake, which is going to be the Achilles heel of this theranostic. So, but you can see that the tumor in the breast by both modalities, FDG and PSMA PET, is quite bright and easy to pick out in the bone and on the chest wall there. So I think, you know, this just leads to many more questions than answers. I think we have some ideas about how we could define studies that would sort out which patients could benefit from CDK4/6 inhibitors when. I think these are really important questions for us, but it's likely that many more patients can benefit from endocrine-based therapy, and that's the other major use, I think, of FES PET, is to think about it rather than committing a patient to a lifetime of chemotherapy. We have many tracers coming up in the pipeline. FES PET is FDA approved, but FFNP, we're about to open a study of that here. FTT, which is the PARP inhibitor tracer, also about to open a study of that here. FFNP is progesterone receptor imaging. And I really hope we are able to get better proliferation tracers as well as immune tracers. But PSMA PET is a promising tool, and it may be something that we can really use to help our triple negative patients and potentially identify a useful theranostic. But really, I think we all know that it's going to be a combination of molecular imaging as well as tissue and liquid assays that will help distinguish which patients can benefit from targeted therapies. Thanks.
Thanks, Anna. Any questions? Well, given that we just have 5 minutes left and my next patient is in the room, I think we might push forward to next month. Please stay tuned. We have additional faculty candidates, I believe, coming to visit next month with seminar, and I'd be delighted to give an update about the SONIA trial and the capecitabine alternative dosing at the next session. So I wish everyone a productive Thursday afternoon. Thank you so much for joining, and we're all here available if there's any follow-up questions. So thanks, everyone.